A special guest today, Fabian, who will be talking to us about the prevalence, the characterization and response to chronic kidney disease in South Africa. I guess she'll be sharing a bit of experience in what she's currently doing in ongoing research on this topic. Thanks again for joining us, June. Thank you so much.
Thank you. Okay, can I go? Right, morning everyone. I've been asked to share some insights on the study that we did in rural Bushbuck Ridge in South Africa. And what we're going to do is just share some findings that we've had on looking at kidney disease prevalence, trying to characterize risk factors, and also thinking through how we respond to CKD in South Africa. So by training, I'm a nephrologist. So thank you, urologists, for your interest in kidney disease. And I think the separations between our professions are kind of hairline. So I hope this will be valuable. So the question is, why did we want to look at chronic kidney disease? And as you all know, it's a common endpoint for non-communicable and infectious diseases. And as an independent risk factor, what we've come to know is that most people don't progress to end-stage renal disease and land up in a dialysis unit. They actually die prematurely from cardiovascular disease. And this results in premature disability. And then obviously they also die from a terminal event, which is usually cardiovascular. So we have little understanding of kidney disease in South and Sub-Saharan Africa. And the other relevant thing is that most of us are not looking at screening and prevention. A lot of the nephrology focus is hospital-based, looking at people with end-stage renal disease, which only services a tiny proportion of people with CKD. And most people in Sub-Saharan Africa today still die because they can't access appropriate care. So we just need to be mindful of that. Sorry, I'm just trying to get my screen to move on. Sorry, I'm just going to do this because I'm not sure why it's doing that. So we started a collaboration called the ARC collaboration, and I see James van Hasselt is on the call, but James was a key part of funding the project. And Malawi and Uganda applied for funding before we did. And their project that they submitted was almost exactly the same as what we submitted. And the funders then requested that we work collaboratively, and that's how the collaboration started. Since then, we have a very strong anchor with London School of Hygiene and Tropical Medicine. We also work with Sherry Winkler at the National Cancer Institute. And with time, we've developed some collaborations further down the line, for example, with a group called Samson, and with UPenn. How does the collaboration work? All of the collaborations are, the study sites are in what we call general population cohorts. And as a clinician, I never really understood what this meant until we started the work in Bushbuck Ridge. But a population cohort is a population-based sample of people in a certain area that undergo an annual census every year. And through these population cohorts, there are mechanisms to provide government, for example, with maternal mortality, child mortality rates. And that's exactly what Bushbuck Ridge does. And that's why the area was set up in 1992, because historically there was no data from the Gazankulu district on any of these survival stats for any of our population. So that's how Agincourt started. Meru is the same. It's got an urban and a rural site. And the cohort in Uganda is primarily rural. So what did we want to look at? Our objectives were quite similar, simple. We wanted to determine the population prevalence of chronic kidney disease. We wanted to look at what risk factors are associated with it. And we also wanted to develop and validate a prediction equation that accurately estimates GFR in African populations. So I thought I would just take you through what chronic kidney disease along the life course looks like, because I think what we also don't appreciate is that pre-conception right into adulthood, there are risk factors, and we focus mostly on adults at a certain point in time. But before conception, your paternal and maternal genetic makeup comprises obviously a contribution. Maternal health is really important. Maternal obesity, maternal diabetes, maternal hypertension, small for gestational age babies. There's lots of teenage pregnancy in Bushbuck Ridge. All of these contribute to compromising your functional nephron mass when you are born. And after that, in most childhood renal diseases, as we know, most of them are monogenic. For example, a perfect example is congenital nephrotic syndrome. But your birth weight is known to influence adolescent development of high blood pressure, diabetes, and obesity. And we are seeing that in population cohorts. For example, in Soweto, we've got the birth to 20 cohort. And your birth weight and whether you have early catch-up growth in the first 2 years of your life influences this. And then you carry into adulthood the same hypertension, type 2 diabetes. We're seeing an emergence of obesity, particularly in our women. And then what we also have no idea is what the impact of acute and chronic bouts of kidney injury are. And that's particularly relevant in our research setting, particularly in rural areas, because there are endemic, for example, infections like repeated bouts of malaria that can cause acute kidney injury. And we previously assumed that you would just get better and your recovery would return to normal in terms of renal function. But what we're finding is that's not always the case. And then obviously we have acquired kidney disease, which is predominantly in South Africa related to infections, but also glomerulonephritis. And then in terms of genetic risk in adulthood, it's mostly polygenic. And we'll go through genetics and kidney disease with APL1. But I think what we have no appreciation of is the effect of toxins, and I'll go through that later. And we do know that smoking is a risk factor for CKD progression. So from between 2008 and 2010, renal medicine in the States was revolutionized through the identification of kidney risk variants associated with a gene called apolipoprotein L1. And this was identified in African Americans. And the reason they started looking for genetic risk in African Americans is because they tend to be at risk of kidney disease at levels that are much higher than any other population group. And they also have a very strong family history of kidney disease. This gene has been tracked back to West Africa. And what it does is it confers protection against African sleeping sickness or trypanosomiasis. And if you carry, it's a bit like sickle cell disease, if you carry one variant of the gene, you'll be protected against sleeping sickness. If you don't have any variants of the gene, you're obviously susceptible to sleeping sickness. But if you have 2 copies of the variant gene, that puts you at risk of kidney disease. And there's been a whole lot of work understanding this and confirming that this is probably a large part of the population attributable risk in African Americans. But how exactly it causes kidney disease, we're still not that sure. But at a molecular level, this variant appears to be toxic to mitochondria, and this variant also is upregulated in kidney tissue, which is why kidney is one of the targets. But essentially what happens is if you've got diabetes or hypertension and you have 2 risk variants of this APL1 gene and HIV, your glomerulus scars in response to any insult. And that's the fundamental mechanism of the CKD. So how does this relate to us? So we have done some studies. There's a big study led by Michelle Ramsey-Fitz called ARWIGEN. And ARWIGEN looks at Burkina Faso and Ghana in West Africa, Kenya in East Africa, and there's 3 different sites in South Africa, of which Agincourt is one. And what I want to show you here is that this blue area is one type of trypanosomiasis. The Rift Valley is along here, and to the east of the Rift Valley is another form of trypanosomiasis. But the allele frequencies, so they call them G1 and G2 for APL1. The allele frequencies vary hugely from west to east to south. And you can see in Agincourt, we have a lot of the G2 allele that gets expressed, as opposed, for example, to East Africa. And what is interesting is that we don't know why there's hardly any APL1 risk alleles in East Africa, but they have very little high ban. And there is definitely a genetic association to the risk of high ban if you have two risk alleles. So the Ethiopians are actually protected against high ban because they don't have these risk alleles. The other thing I just wanted to show you is that there's huge variation when we look at the high risk alleles. So those are people who have got one or two risk alleles. They fall into what we call the high risk genotype group for developing kidney disease. And what you can see in East Africa is that these high risk alleles are relatively low in frequency. The West is kind of in the middle, and that's Burkina Faso and Ghana. And in South Africa, there's huge variation between the different ethno-linguistic groups. And the highest are actually in the Venda, followed by the Tsonga, which is here in Bushbuck Ridge. So what we don't really understand is why there's such variable penetrance within Africa compared to African Americans. And what we also don't really know is how this affects the development of kidney disease. And the reason I'm harping on about it is because RWGen has looked at the association between APL1 and kidney disease. And what's really interesting is that we don't see any association with low GFR. But in the group who have albuminuria, the frequency of people with two risk alleles goes up. And the recessive inheritance, which means you inherit two variant copies of the gene, gives you an odds risk ratio of about 1.6 to develop albuminuria. So there's a whole lot of reasons why we're trying to think through why we're not seeing an association with low GFR, and we can talk about it later, but I just wanted to alert you to the fact that we are looking at this in South Africa. So as you all know, we define chronic kidney disease by looking at GFR, and our cutoff is 60 moles per minute, and also albuminuria using the KDIGO guidelines. And in terms of GFR, you can either measure it or you can estimate it. Measured GFR is more accurate, but it takes about 6 to 8 hours, so it's totally impractical. And we reserve it for special cases where we can't estimate GFR properly. But for most of us as clinicians, the estimated GFR is what gets used in millions of people every day. We also use this to stratify GFR by stage, where stages 3, 4, and 5 fall into the chronic kidney disease category. So I just thought I'd give you some kind of insight into the study site and what we actually did. So as I said to you, Agincourt is a health and demographic surveillance site. There's about 90,000 people in this area here, which is what we call a study site, and there are 31 villages that have agreed to participate in their annual census. What we did in terms of the study is we went to people's homes. This is me over here. This is one of our field workers. And there's a whole way of approaching the household, which I had to learn. You then give them permission to be there, and then the head of the household gives you consent to consent participant. So it's a very different consenting process compared to the very kind of individualistic, I'm consenting this participant to what, that's how we train, but Bushbuck Ridge was very different. The other thing is that each household that's part of the health and demographic surveillance site is GIS located because there's no street names. All the roads are sand roads, and the team literally identify people in the sample and get in the car with the map, and off they go to find a participant. This is our team getting ready every day to go out into the field. And as I said before, what I learned is that consent is communal. So this lady is the head of the household, her daughter is the participant here, and this is her grandchild, and everyone participates in the process, even in your HIV testing. So there's not too much confidentiality. This is one of our field workers doing anthropometry. And we did a lot of point of care testing, but we also collected blood and urine. And what I also learned is that when it gets very hot, these devices for point of care that are made in Norway stop working. So there were quite a few logistical challenges in terms of making sure the field work gets done properly. So what did we find? The population prevalence of chronic kidney disease in Agincourt, we recruited 2,021 people out of a sample of 2,700. And what I thought I would do is contextualize the prevalence that we found in terms of what Uganda and Malawi found, because we did all of these studies in parallel. And what I can show you is that on the whole, our populations are young, which is typical for low and middle income countries compared to high income countries. About 60% of the samples were women, because a lot of men migrate out of the study areas for work. And what you can see is that we think South Africans are kind of ahead of the epidemiological transition, because we're definitely the most overweight. There's lots of hypertension wherever we are, highest in urban Malawi actually, and our diabetes rates are going up. But what I wanted to show you here is the contrast between rural and urban Malawi, where hypertension is higher in urban Malawi, people are more overweight in urban Malawi, and there's definitely more diabetes. South Africa also has the highest HIV positivity rates amongst the 3 sites. And what we found that was really interesting is that based on a low GFR, our prevalence of CKD is really, really low, which is not what we expected. And I'll go through that a little bit later. In terms of CKD risk in South Africa, we did do APL1 screening, and we found that APL1 is associated with developing kidney risk. Hypertension and diabetes by far are our strongest risk factors, and being HIV positive as well. About 85% of people in the study area are on antiretroviral therapy. What was very interesting in terms of diabetes is that there's a lot of diabetes unawareness. There's far less screening for diabetes, and we didn't diagnose a lot of people with diabetes, but in the people that we did diagnose, they had absolutely no idea that they were diabetic. There was one young girl studying for matric, and she couldn't see, and her glucose was 36. So it seems that we far behind in terms of screening, public education and awareness for diabetes, and it is definitely emerging in the community. The other thing I didn't appreciate through my own ignorance in Bushbuck Ridge is that there's a lot of other stuff that we didn't think about going into the study, and I think it's because we used a kind of high income informed lens of thinking about diabetes and hypertension and obesity as traditional risk factors. But Bushbuck Ridge is in an endemic schistosomiasis area, and I remember being in the lab the one day and just looking at all of these urines coming in, and the sediments in the urines are unbelievable. So just to reset, these are people who are not presenting to clinics because they have dysuria or frequency or any symptoms of anything. These are just people randomly sampled from the population. And this kind of urine here with this incredible sediment over here is quite commonplace. And I started wondering why this is and what this could potentially be. And these are the things that we didn't think about when we did the study. What we did do, probably quite inadvertently, is we did screen for urine dipsticks every time we saw people. And what we found is that if I take out people with albuminuria, so we're just looking at the non-albuminurics, about 30% of the population that we screened have unexplained leukocyturia and hematuria. And what's really interesting, because I think most people assume that the leukocyturia is based on some kind of infection, but only 50 of 2004 people were nitrite positive on their dipsticks. So again, we can discuss, and maybe with your urological expertise, you can come up with some ideas for what this might be, but I'll leave that for later. Because of the schisto risk, what I also realized in the area is that screening for schisto is non-existent because you need a fresh urine sample to get to the lab. And what happens with the nurses in the primary healthcare clinics is that that urine can sit there for up to 24 hours before it gets to an NHLS laboratory. So there's no screening, but there is empiric treatment based on hematuria, provided they have urine dipsticks. And the urine dipsticks testing in the clinic is almost non-existent. So I'm not sure if people are even being treated, or if they are, maybe it's on reported symptoms of hematuria. But what we did do is we set up screening in the lab, and the Adjunct Research Laboratory actually screened patients, and our population prevalence of untreated schisto was about 5%, which is quite high in terms of WHO criteria. And the schisto treatment program in Bushbuck Ridge has completely unraveled. HIV kind of took first place. And even with COVID, etc., it's just kind of fallen off the map. So there's no treatment and prevention strategies. We're not screening school children. And women and school children are particularly vulnerable, especially for genitourinary schisto. So what you can see here is that a lot of our albuminuria is associated with schisto, which makes sense. But the implications for that are that if we're diagnosing CKD based on albuminuria, I'm not sure how relevant that is in our setting, and I think these are things that we need to think through. There's no association with GFR, which makes sense. And the odds ratio in terms of having a positive dipstick hematuria is about 3.6, which I think is why people just treat empirically if you're from an endemic area and you have a urine dipstick positive. So in terms of our risk factors, I've shared those with you. In Malawi, older age, being hypertensive, having a high level of education, because often those are people who migrate to the urban areas, and fishery and farming were identified as risk factors. And I think this is where potentially urine abnormalities could be described, could be explained, because there's a lot of agricultural toxin exposure, and there isn't a lot of regulation around which agricultural toxins are used. And there's a lot of farming and fishery in rural Malawi. And in Bushbuck Ridge, people working on farms is the second most common form of employment, and there's no regulation here in Bushbuck Ridge either. In Uganda, older age hypertension and anemia were associated, which is not a surprise. So basically, after completing our population prevalence studies, the questions that kind of nagged at us were, why are there so few people with what we define as a low GFR? Because everyone says that there's going to be an epidemic of kidney disease in sub-Saharan Africa. We have persistent infectious diseases. We have emerging non-communicable diseases. All of these cause kidney disease. So what we expected is this really high prevalence of kidney disease, and we didn't find it. So that was the part of our next study, which is where we measured iohexol GFRs. And I just want to take you through the evolution of GFR estimating equations, because the equations that we use are recommended by the KDIGO guidelines, but none of them have been validated at population level in sub-Saharan Africa. There have been a handful of small studies throughout West, East, and South Africa, of which some of our team at WITS have been part of. And what we know is that if we adjust for the African American coefficients in African populations, they overestimate GFR to quite an extent, and I'll show you that a little bit later. So the rest of the world, or the West, has kind of assumed that the African American coefficient is extrapolatable to every continental African population, and that is incorrect. The problem, though, is that we don't know what the best equation is. And aside from the CKD epicreatinine, there's also cystatin C. The Scandinavians developed something called the full age spectrum equation, or the FAS equation, and the Lund-Malmo equation. And what's really interesting is that these equations have been around for a long time, but I'd never heard of the Lund-Malmo equation when I started the study. And the significance of that, I'll go through as we go. So the aim of this part of the study was to look at measured GFR using plasma clearance of iohexol. And the reason we chose iohexol is because you don't need a radionuclear facility to do it. So most of the GFRs that get done, for example, UC2 or FITs, are radionuclear, but we didn't have any of these facilities in our rural areas. So we chose iohexol because it's an intravenous push, and then you measure at serial time points after that, and then you work out the plasma excretion of iohexol. So what we wanted to do is we wanted to compare EGFR equations to iohexol GFR. And then we thought, if equations perform really badly, we'll try and generate our own EGFR equation. And then once we've worked that out, we'll be able to determine what the true population prevalence of kidney disease is. So this is our study site. This is the Agincourt Research Laboratory. So what we did is consented participants were brought in and they spent the day with us, essentially. This is one of our participants, it's one of our nurses in the iohexol room. This is how we administered the iohexol. This cannula stays in for 4 hours afterwards, and that's what we sample from. And while they were with us, we also did an ultrasound of their kidneys to just try and look at kidney size. And what's really interesting is our kidneys seem to be a little bit smaller than high-income setting references. We also did DEXA scans on everybody to test the muscle mass creatinine hypothesis that African Americans have higher muscle mass, and that's why their creatinines are higher. And then this is Bongi in our lab processing all of the specimens, which then got shipped to Johannesburg to run the iohexols in the central lab. So what did we find? What we found when we looked at our iohexol measured GFR in Uganda, Malawi, and South Africa is that race-based coefficients overestimate kidney function in sub-Saharan Africa, which we kind of knew, but we've now shown at a much bigger, with a much bigger sample size. There were over 2,500 people in the sample at the end. Even if we take the race-based coefficients out of the GFR estimating equations, the performance of creatinine-based equations in our populations is still poor, and they still overestimate GFR. When we compared all of the available creatinine-based equations, the Lunt-Malmo equation was actually better than the CKD-EP equation, and that's something for us to consider going forward. And then when we tried to model a new equation, we actually couldn't model anything that's better than the existing ones. And we think that that's because creatinine is a relatively poor biomarker for kidney disease in South Africa, and I'll go through the reasons for that. And what we did find, which perhaps is relevant for us to think about, is that cystatin C seems to be better than creatinine for estimating GFR in our populations. And for people with a GFR of less than 60, cystatin C diagnosed double the amount of people with a low GFR compared to then if we just used creatinine. So there are a whole lot of different ways to assess GFR estimating equations, or to evaluate how good or how bad they are. And I'm not going to go through all of those metrics because I don't think it's relevant to what we're trying to show. But what I am going to do is just talk you through this tau, because this will show you the extent of overestimation of the GFR equations. So this is calculating or estimating a GFR in comparison to the measured GFR for the same participant. And the difference between those two is what we call the absolute bias. So it's the estimated GFR minus the iohexol measured GFR for that person. And all of those are put together with a 95% confidence interval. So when your GFR is well preserved, that's this group over here, there's not a lot of overestimation. I mean, ideally, we want no difference between eGFR and mGFR, and we want everything to sit on this line, but that's not happening, obviously. And what I've included here is that this is the CKD-EP cystatin C equation. This is the Lunt-Malmo equation in orange. This is MDRD, because a lot of people in Africa still use the MDRD equation with ethnicity. And this is CKD-EPI with ethnicity, which is also still very commonly used throughout Africa. What I want to show you in this slide is that as your kidney function worsens and your GFR starts to drop, the degree of overestimation increases. So in the group here, where we want to pick up as many people as we can with a GFR of less than 60, we can overestimate that GFR by up to 40 mils per minute, depending on the equation that we use. And the worst of those is the CKD-EPI creatinine equation. The better of them is the cystatin C equation, but even then you might be 20 mils off. So cystatin C is better, but it's not ideal, but at least it's performing better than any of the creatinine-based equations. So what we did then is that we tried to look at what the implications might be at population level, because if we're missing all of those people with GFRs of less than 60, we're obviously not going to diagnose CKD. So what we did is we used a model to impute predicted GFRs based on iohexol GFR. And then Michelle Ramsey shared her data from RWGen. So this is over 20,000 people that we're looking at here. So it's West Africa, East Africa, and Southern Africa. And this small graph over here is the prevalence of CKD if we use the current CKD-EPI creatinine equation. And if we base or predict the GFR based on our iohexol GFRs, the prevalence of CKD goes up quite substantially, actually, between 3 and 5 times. So we've had a lot of pushback from reviewers saying this is completely ridiculous. How is this even possible? But the point we do want to make is that, sure, this is a model, but the bottom line is that we're underestimating the prevalence of CKD based on GFR. And if you look at population surveys of African Americans who are considered a very high-risk group in the US, their prevalence is around 15%, which is similar to what we're finding here. RWGen population prevalences are a little bit higher because the RWGen group is older. They're people between the ages of 40 and 60. So using equations that aren't properly validated to estimate kidney function in sub-Saharan Africa has implications at the individual level, and it has obvious implications at the population level. So the next question that we weren't sure of is, everyone's assumed that because African Americans have higher creatinine than other population groups, surely the same must apply in sub-Saharan Africa. So to test this, we looked at our population creatinines and we compared them to the Health Survey for England. Because of our collaborators at London School, they were prepared to share the data set with us. And what you can see from this slide is that the assumption that African populations have high creatinine based on what's seen in African Americans is incorrect. This is the serum creatinine for men in England, and these are the serum creatinines for all of our other population groups from RWGen and ARC here in South Africa. So this is RWGen and this is ARC, but here's serum creatinine for England for men, and here's serum creatinine in England for women. And you can see the same trend throughout. So in all of the populations that we tested, our serum creatinines for men and women are lower than what we're seeing in a high-income country. So the next question was, well then, why is creatinine such a poor biomarker for kidney function? And we think there are a few reasons. So this is quite nitpicky, and most of us don't realize it, but there are 2 different methods for assaying creatinine in the labs. The one is called the Jaffe, and the other one is the enzymatic. And the Jaffe has a correction that drops the creatinine by about 10 micromoles compared to the enzymatic assay. So if you send a creatinine to a lab and they run the enzymatic assay, it'll send you back a reading of saying the creatinine's 80 micromoles per liter, With the Jaffe method, it's 70 micromoles per liter. And that's what we found in our study. So just the method that the lab is using changes what your creatinine reads. And if that's reporting lower, then obviously your GFR will be higher. The problem with Jaffe versus enzymatic is that it's recommended that we all shift to using the enzymatic method, but the Jaffe is very, very cheap. And that's why most of the labs in sub-Saharan Africa are still using the Jaffe. Even at the NHLS in Joburg, I was asking some of our colleagues, there are some labs that do the Jaffe, and then there are some labs that do the enzymatic, but it's not even rolled out consistently within the NHLS in South Africa. What's also interesting is that some of the private labs don't use the enzymatic either, even although the private sector is better funded. So I think there are structural things like that that we could address. The other thing is comparing African populations to high-income settings is that we seem to have lower BMIs and smaller body surface areas, and by inference, perhaps lower muscle mass. And that's what we hope to look at in the next part of our study, using our DEXs that we did up in Bushbuck Ridge. The other thing that I think we also forget is that there are adverse perinatal and early childhood factors that do affect functioning nephron mass. And as I mentioned, it does look like our kidneys are a little bit smaller. But also maternal malnutrition gives rise to short stature and lower muscle mass. And these might all be things that contribute to creatinine performing relatively poorly in our populations. There's also wasting with chronic infections like inflammation and TB. And also just poverty and food insecurity make people eat less meat. In Malawi, for example, one of our teams said that if they eat meat once a month, it's a lot. So these things are real, and we do need to factor that in. There's also quite a lot of undiagnosed liver disease in Africa, and Wendy Spearman's published quite a lot of this from UCT. And the other interesting thing is that on a GWAS analysis in Uganda, they identified a mutation in a gene called GATM1. And this gene influences or controls creatinine excretion at the level of our tubules. And there's been quite a lot on African Americans excreting more creatinine at the level of their tubules. And this mutation hasn't previously been described in high-income settings. So we're not sure if perhaps even at the level of the tubule, we might be secreting more creatinine, and maybe that's also contributing to a relatively low serum creatinine for a given GFR. And what we also found is that our South African women who have a very high prevalence of HIV tend to have lower creatinines than everybody else, despite being bigger and heavier and having the highest BMIs. And we also know that there are some antiretrovirals, even the newer ones like dolutegravir, do have an effect on tubular secretion of creatinine. And these are also things that we want to look at going forward. So in conclusion, in terms of CKD risk, we found that high-risk genotype for APL1, hypertension and diabetes are commonly associated with chronic kidney disease. But what we also realized is there are context-specific factors and unexplained urinary tract abnormalities that might, for example, arise from endemic infections like genitourinary schistosomiasis, but also perhaps could be part of an interstitial nephritis from environmental toxins, particularly agricultural pesticide exposure. And I've done some additional reading, and there's an NGO here in Bushbuck Ridge called Award, and they're looking at water security. And the acid wash-off from the mines, because it changes the pH, tends to precipitate heavy metals. And what we are finding is that lead toxicity and cadmium toxicity appear to be increasing. They've done some studies in schools along the rivers where the coal mines drain off into, and the lead levels in those children that are attending school are about 5 times higher than WHO recommendations. So I think these are all things that we still need to look at, might potentially explain what we're seeing. There's also the impact of traditional medicines, and then, as I mentioned, acute kidney injury, repeated bouts, and what that does in terms of developing chronic kidney disease. In terms of how we measure GFR or how we estimate GFR, I think this is a moving target, but I think what we can say is that if we use creatinine-based GFR estimating equations, we're probably underestimating the prevalence of kidney disease in sub-Saharan Africa. Cystatin C is better, and what I would suggest is that if you do suspect that someone's got CKD, if you are going to do a confirmatory test, I would suggest using cystatin C to confirm the CKD rather than a creatinine-based GFR. And I think what it also highlights is that we need local guidelines to inform individual care. We do need better biomarkers, and it would be great to have real-time testing for CKD screening in terms of uptake, for example, in primary healthcare clinics, because it's really hard for primary healthcare nurses to actually diagnose kidney disease. Without a point of care device, that tube might sit again for 24 hours. And Jaya George in Joburg has shown with some of her group that if you leave a tube of blood for longer than 12 hours, your creatinine assay changes as well. So I think we should rather be rolling out point of cares. They might not be as accurate, but it's a lot better than leaving a tube lying around for 24 hours and maybe never getting a result from the NHLS in terms of resource-limited primary healthcare settings. And then I think hopefully what we would like is that this work informs some evidence-based algorithms for clinical practice, because I still think there's very little awareness that diabetes and hypertension cause kidney disease. But if you ask the primary healthcare nurses about screening for kidney disease for HIV, everyone does it because it's protocolized. So I think we can learn from HIV. The nurses do it without batting an eyelid. But if you ask them whether they screen their diabetic patients, there's no consensus and there's no agreement, and it's not being done. So I think I'll stop there. Just to say a huge thank you to all our participants, to the Agincourt rural community, and yeah, to everyone who enabled this. We would never, there are just so many people who were involved. And James, also just a shout out to you. Thank you for all your support for this project. And I'll hand over for some questions.
Thanks a lot, John, for such excellent work and a very informative presentation. Yeah, no, you're quite right. I mean, CKD is really a problem in our country, and obviously the implications of that are quite huge in patients getting CKD because there's very limited resources in terms of dialysis. Thank you so much for the talk. See, Prof. Mtambira has a question. Prof, you can go ahead.
Morning. June's absolutely brilliant. James told me a little bit about the study and I read a little bit, but your presentation has really clarified so many things I was asking. I just wanted to ask a couple of practical questions. Number one, how expensive are the different tests? Like if you're going to do estimated GFR, you're going to do the cystatin C, what's the difference in cost? And the second one is practically, because this is obviously going to take some time for people to recognize. It might be 5, 6, 7, 8, 9, 10 years. For my average patient who comes into the ward now, and I see that the guy I'm suspecting, hey, this guy might be having a problem. Should I just be maybe putting 10% on the estimated GFR, or I mean decreasing it or whatever by 10%, or what should I do practically just to make my life easier and maybe possibly save some patients?
Oh, yeah, that's a hard question. The cystatin C price, cystatin C is expensive, and a lot of the labs haven't set up QC. So for example, I think at CLS in Joburg, it will cost you 200 Rand to do cystatin C, where it costs 5 Rand for a Jaffe. So the price differential is big, which is one of the barriers, particularly for the rest of Africa as well, because you need labs to be able to set up the QCs. In terms of what to do, Sean. I think rather than subtracting or adding X number of mils of GFR, if it's somebody, I mean, we've been thinking about this a lot, and you raised an important issue, is around, is a GFR of 60 appropriate in our population? So the cutoffs of 60 are developed from studies in high income settings where the average age of the population is 55. And as I showed you, our average age of our populations is 35. So there is some debate in the literature, is that if you're 35 years old and your GFR is 60, you're way ahead of the curve in terms of losing functional nephron mass. So the debate has been, should we rather be using a cutoff of 75 for young people or people under the age of 40 to screen them? So in the absence of anything else, I would say if you've got someone under the age of 40 whose GFR is less than 75, I would rescreen them with cystatin C. That's what I would do. And then I would use your cystatin C GFR to inform what you're doing. I don't know if that's helpful.
Brilliant. No, thank you.
Thanks a lot for the question, Prof. Any other questions? Just for interest's sake, I mean, I see at that community where you're doing a study. I don't know if you guys had time, or did you find that as an opportunity to offer health education, or you probably didn't have such a team? I mean, because you've also taken, like, I saw how you guys were screening checking blood pressures, HGTs and stuff. Did you find that as an opportunity to also provide some health education? I don't know if you had some people.
Yeah, so I mean, part of the reason why we're not picking up people with low GFRs is that they die without access to care. So there's definitely a survival bias in all of our population-based studies, because none of the study sites have got access to renal replacement therapy. So what is interesting is that the community here is changing, because research has been done in this community since 1992, basically. But what we found with participants, and we do have a very active, it's called a public engagement office. So we do have a team of people that give people the results, they tell them what the study found, et cetera, et cetera. And there's a lot of interest in kidney disease, actually. And what we found is that the participants wanted to know what their own results were. They weren't happy for us to just say, oh, in this village, this is what we found, and schisto is a problem. They wanted their own results. So what we did is we used REDCap, but we generated an automated sheet that would give each individual person their results. And at the end of the study, we spent a month and we went back and we gave people feedback and we gave them their results. And the relevance of that, even in Malawi, is that a lot of people don't have these results. For example, when we did the ultrasounds, if we found an abnormality, there's no one to refer the patients to, because there are no local ultrasound services, not even at the local hospitals like Tinswalo. So people were very interested. We did give them individual feedback. And then for people who we did find had kidney disease, we did refer them. But logistically, it's an absolute nightmare to try and get people to. So the nearest referral hospital is Rob Ferreira. Rob Ferreira doesn't even have a renal OPD. So trying to get patients into care is really, really hard, which I think is also why they just don't get care, and the nurses just don't refer, because they don't know, there's no mechanisms really. So I think those are other things that we need to be mindful of. I don't know if that answers your question.
Yeah, no, it does. Thanks a lot. I see James has a question or a comment.
Yeah, thanks very much, June. Thanks for a really excellent presentation. Two things. I mean, one is that you're challenging a very established way of doing things, or an established paradigm around how we look at kidney function in our patients. And the other thing I'd like you to just talk about is one of the things you did is to take your findings around schisto to NICD at a very early stage, and actually were able to establish an intervention from your research and to get the local clinics to accept your research findings and treat on the basis of your research findings. So if you could just talk about those two things and perhaps some of the challenges you've had in getting your results into the public domain in terms of publication.
Please unmute, June.
Yeah, I was just, thanks, James. You forget about all these aspects of the study, but when we set up the screening, we only had one microscope in the lab, and then we had a power surge, and the plug attached to the microscope was not surge protected. So that began a whole saga. But the bottom line is we lost our microscope because they only serviced them in Joburg. Eventually, I went to the anatomy department at Wits and I said, please, can I just steal some of your old manual microscopes? And I took them up to Bushbuck Ridge and they're still using them. But James's point is correct, because I think it's the intersection of research and clinical service. So what we found is that we had trained the staff, we had the NICD oversight, NICD was doing all of our QC, and we were picking up cases of schisto. And I guess the obligation then is that you need to treat the participants. And then the question was, well, the nurses would say to us, but this isn't an NHLS lab result, you know, how do you expect us to treat this? So there was a whole lot of negotiation between the study site and the primary healthcare clinics, and the nurses did eventually accept that our results were as valid as we could get, and they did actually treat the participants. But these are the things that I didn't even think through when we started the study. So yeah, I guess it's just about that fine line, you know, and it's about having good relationships. There's a very good relationship here between the study site and the primary healthcare clinics. But if that didn't happen, I'm not sure whether we would have been able to get care for the participants. The other interesting thing, as James was saying, is that our findings, yeah, we're really struggling to get the paper published. We have had a lot of pushback from US-based journals, and we're almost 7-8 months down the line, and we're still struggling to get the paper published, which I think has also been a learning curve for me, because I kind of thought, oh, you know, we've done this research and this is what we found and it's so exciting. And you kind of think, well, the hardest thing is to get the research done and to write the paper. But we are really struggling to get the papers published. So yeah, it's an interesting, it's just been an interesting thing. But yeah, when we have, hopefully you'll be able to see it. At the moment it's with Lancet Global Health, but it's been there for 4 months. So yeah.
Yeah, thank you so much again, June, for excellent presentation. Very interesting work you're doing in the communities and looking into CKD. Yeah, thanks again for your time. Thank you everyone who joined this webinar session. Yeah, I'll see you guys in the next week. Thanks.
Thanks for the invitation.